Assalamu alaikum. This is the Cystourethroscopy of a patient who is having enlarged prostate of around 85 grams and is having two stones in the bladder, one 14 millimeter and the other one 12 millimeter on ultrasound with a significant post-void residual volume. So you see that the prostate is enlarged, there is a huge median lobe and there are two stones and the bladder is mildly trabeculated. So you take the stones first and while the median lobe is there, it's really difficult to perform litholipexy. So care must be taken not to cause bleeding from the median lobe or the bladder, because slight bit of bleeding will lead to impairment of the vision and then litholipexy becomes almost impossible. So care must be taken and time must be taken. One should not be in a hurry, and always the mucosa posterior to the bladder stone needs to be in the vision. You can see in the vision that we have taken a little bit of mucosa here. You can see, yes, here, but there is no significant bleed, because we quickly, when we realize that we have taken mucosa along with the stone, we just release the stone as well as the mucosa. So the stones are hiding behind the huge median lobe. So once we are sure that there are no big pieces, the small pieces can be retrieved using Alex evacuator as well. So instead of causing more bleeding, we decided to switch to the resectoscope and start resecting the median lobe. So as a general rule, in transurethral resection of the bladder of the prostate, we must create a crater by resecting the median lobe first, so that circulation of fluid in the resectoscope becomes efficient, and the circulation is efficient, the vision will be better. So resection of the median lobe is continued until, number one, the fibers of the bladder neck are visible, and number two, a sufficient crater is created for the fluid movement and circulation. Complete resection of the median lobe at this stage will lead to undermining of the bladder neck. This same crater is continued towards the biromarginum. So control the bleed or the active bleeders before you go on to resect a new area, because if a small bleeder, you can see the bladder neck fibers here. So the median lobe resection for the moment is complete. So you always coagulate the resected areas before starting resection of the new area, because you will be facing new bleeders while resecting, and at the same time, if the prostate is bleeding from the contralateral lobe as well, so this will lead to impairment of the vision, and that's the procedure will become more and more difficult. So I start the base of the lateral lobe, and then slowly and gradually I move towards the upper side. I start resecting the 5 o'clock position, and slowly and gradually I'm moving upwards. Since the ultrasound was showing 115 grams prostate of this patient at presentation, so we gave him a combination therapy of dutasteride and alpha blockers. He used it for a good 4 weeks, and now you can see very clearly the effect of that dutasteride, that the prostate is not juicy at all, and it is not bleeding as one would expect a big prostate. And the second good thing was that after use of combination therapy for 4 weeks, the prostate size on the follow-up was 85 grams instead of 115 grams. You can see a small breach in the capsule of the prostate, so I was expecting a bigger prostate. That's why I was resecting very boldly deep into the prostatic parenchyma, which has led to the breach in the capsule at a small location. However, we are lucky that we were not deep enough. So coagulate the area which was already resected on the left lateral lobe before going on to the right lateral lobe, so that it doesn't impair the vision. So starting from the 7 o'clock position and moving slowly and gradually upwards, you can see many fibers. However, for the resection to be complete, we need to resect more and more of parenchyma of the prostate, and in the process on this side as well, we were able to breach the capsule at 1 or 2 locations. However, the breach was not deep enough to produce any significant bleed. We were lucky. So when you are resecting a big sized prostate, you tend to resect deeper, and this may lead to at times breach in the capsule. Once there is breach in the capsule, this may lead to a few things. A breach in the capsule. Number one is that you may encounter a lot of bleed during the procedure, and the more you try to coagulate that bleed, the more it bleeds. So that bleed usually cannot be controlled easily. For that, you may have to inflate the balloon in the prostatic cavity under fluoroscopic guidance. Number one thing. Number two is that post-operatively, patient will be having more irritative lower urinary tract symptoms in the form of frequency, in the form of urgency, especially extremes of pain during maturation. All these are signs of breach in the capsule. So it is an unwanted thing to happen. However, it may happen, so one must be able to deal with the situation. So we have emptied the bladder quite a few times with the ilex evacuator, taking out all the resected chips, and then this leads to more and more of parenchyma coming into the cavity. As the cavity stretch is reduced, when resection is going on, there is a lot of fluid going on. So the capsular region, the prostatic urethral region, is quite overstretched, and the beginners may think that they have completed the resection. However, completeness of resection must always be decided after the bladder is emptied quite a few times. So here you can see that we are remaining with very little of prostate to be resected. majority of the areas have been relieved of obstruction. Care must be taken not to use diathermy when uromontanum is in vision, number 1. Number 2, care must be taken not to come distal to the uromontanum while using the cautery, especially the coagulation, because that can seriously lead to sphincteric injury. So a capsule breach in the lateral lobes is not as significant as in the anterior and the posterior lobe, because a breach of the capsule of the anterior lobe will lead to bleeding from the venous plexuses of the prostate, which can be life-threatening. And on the posterior side, a breach in the capsule may cause injury of the rectum. So anterior and posterior lobes need to be resected carefully, keeping in view the anatomy of the capsule. So fine tuning is remaining here, and the rest of the procedure is complete. In a while we'll start coagulating the prostatic cavity. So now you can see very nicely the prostatic cavity is wide and open. You can see the area of the breach in the capsule here. However, I'm trying not to fiddle anymore with that area of the capsular breach, because the more you try to tackle it, and the more it becomes problematic, widening all that breach, increasing the size of the breach in the capsule. The size is increased, the depth is increased, and bigger vessels are opened. So one needs to be really careful. So more of median lobe is coming up. So we start another session of resection. However, I'm trying to not take deeper chips this time, because we all know that we are near to the capsule. You can see the small black dots, which are a sign of nearness to the capsule. While discussing the breach in the capsule, we made another hole as well in the capsule, and this needs to be avoided. A little more of fine tuning, and then we will start coagulating the cavity. Always remember, over resection is never good. If it is under resected, if the patient is not symptomatically relieved, you can do another session of TURP after some time, but an over resection leading to complication cannot be reversed. Care must be taken. And now we have started coagulating the cavity. I usually start by coagulating the bladder neck fibers, not completely, because the more you coagulate this area, the more it is prone to bladder neck contracture and stenosis. However, the areas which are bleeding actively need to be properly coagulated. Here I am trying to avoid the coagulation of the cavity in the capsule which was open, and I am trying to coagulate the edges of that opening, because if I If I try to coagulate the center of that opening, this will lead to increase in size of that area, and it may open up more vessels, which then will not be able to be controlled. So I have coagulated all around that breach in the capsule instead of going into the center of that cavity. Same is the case on the right side. This is the breach in the capsule, so I'm coagulating the edges of it, which may bleed, and I'm using minimum cautery in the center of that breach. Thank you very much for watching.